So many parents whose child gets diagnosed with ADHD ask about alternatives to medication. And on this podcast, we've talked about medication, we've talked about behavioral therapies, mindfulness, and classroom accommodations. And today, my guest will discuss an empirically supported non-medication treatment for ADHD, Trigeminal Nerve Stimulation, or TNS. Not sure what that is? Well, that's why we're having this conversation. My guest today is Dr. Sandra Loo. She's a professor of psychiatry and director of pediatric neuropsychology within the Department of Psychiatry at UCLA David Geffen School of Medicine. Dr. Loo is a licensed clinical psychologist and translational researcher whose work over the past 25 years has encompassed genetic, electrophysiology, and neurocognitive biomarkers within ADHD and other neurodevelopmental disorders. She has published over 150 peer-reviewed journals and book chapters on these and related subjects. I am so thrilled that she is here with me today.
Millions of kids struggle with learning, processing, and social emotional difficulties. These challenges interfere with their ability to reach their full potential. Dr. Karen Wilson is here to help. Her extensive background in pediatric neuropsychology and higher education have prepared her for this unique mission. Listen as she delivers content to inform, educate, and empower parents and educators. This will enable you to identify challenges that kids face and get them on the road to achieving their full potential. This is Diverse Thinking, Different Learning by Child Nexus.
Hello, Dr. Loo. Welcome to the podcast.
Hello, Dr. Wilson. Thank you so much for having me.
I'm so glad that you're here. And this conversation actually stemmed from another conversation we had at a luncheon about the work that you're doing at UCLA. And I'm so excited. I said, I have to talk about this topic on the podcast because, you know, as professionals, we work a lot with parents who have kids with ADHD. And the first question when a parent is given a diagnosis is, you know, what are the treatments and are there any non-medication treatments for ADHD? And so, you know, I love the work that you're doing. I think it's just so important just to bring this to people's attention because oftentimes people aren't aware of some of the newer developments in ADHD treatment.
Agreed. And we're super excited as well because this is a very new treatment. And I feel like getting the word out, spreading information about it is probably the most important thing at this stage. And then we are also doing a large clinical trial to extend the work that we've already done. We've done one small study and now we're doing a larger study. So to better understand the treatment, who it works for, how it works, and see if we have any predictors that we can use to identify children who are most likely to respond to the treatment.
Wonderful. And depending on the studies you cite, you know, we know that about 1 in 10 children have been diagnosed with ADHD, and there are many established treatments that have been developed through the process of clinical research, from medication to behavior therapy, mindfulness, all of those interventions. And what parents may not have heard about is nerve stimulation. And it can sound a little bit scary when you think about it, but I'd love for you to kind of help parents better understand, you know, what are we talking about when we're talking about nerve stimulation or specifically trigeminal nerve stimulation for treatment of ADHD? What does that mean and what does it look like?
Sure. So trigeminal nerve stimulation is the first FDA cleared treatment for ADHD for kids 7 to 12 years old. And it's a mild stimulation that increases brain activity indirectly through the trigeminal nerve. The trigeminal nerve is a cranial nerve, which is located in the forehead. So children wear what kind of looks like a Band-Aid on their foreheads at night. And that's where and then it's connected to a stimulator that looks a little bit like a TENS stimulator, if you've ever seen one of those. So it's a very mild stimulation. And our research shows that when you stimulate this trigeminal nerve, it increases activity in the brain areas that we think are involved in ADHD. So children wear it at night while they sleep, and they take it off in the morning, go about their day. And then after about 4 weeks of nightly stimulation, we have seen significant improvement in ADHD symptoms in, I would say, about 50% of the kids that we've tested so far.
And so when the kids undergo this treatment, what it sounds like this is something they do while they're sleeping. It's not something they're wearing during the day. And so what does that look like at night when they're putting it on? And what can the child expect to experience or feel? Do they feel anything during this process? What is that like for the child?
Sure. So basically parents help their children apply the electrode, the Band-Aid on their foreheads at night. We have, within our study, we've already shown them how to use the device, the stimulator, and we've also helped them find the right level of stimulation, at least to start with their child. So they put on the stimulator at night. It's the stimulator is maybe the size of an iPhone-ish. So it can either be, and the cords are pretty long. So it can either be placed on the pillow or on the bed next to the pillow by the child, or there's a little clip and they can wear it on their pajamas. So, especially if the child is, for example, a restless sleeper and tends to move around a lot. So basically, we ask that children try to wear it for about 8 hours a night. And then they can when they wake up in the morning, they take off the electrode and they go about their day. And then the next night, parents work with their kids to apply a new electrode and do the stimulation. So what we've heard is that the older children, so we're seeing children from 7 to 12 years old, and the older children, 10, 11, 12, they feel very comfortable with this digital world, of course. And so they pretty much take over applying it themselves in large part and take responsibility for putting on the electrode, setting the device, and starting the stimulation. So that usually happens right before bedtime. And then people actually experience it very differently. It feels like a little tingling sensation on the forehead. But the stimulation level is very individual. So, which is why we help people find the right place. So we want, the stimulation, as we instruct parents and children, should never be uncomfortable, painful, cause any discomfort. It probably functions a little bit like a white noise while kids sleep. So we have heard that some children fall asleep faster, sleep better, more soundly through the night, and things like that with the device while they're wearing the device. So, I think once you find the right stimulation level, then, you can pretty much leave it there. I personally have experienced that it is such a mild tingling sensation that sometimes you acclimate, you habituate to it. And so, occasionally you might want to increase it a step or two, but really we don't have any data to suggest at this point that you need to have, really strong stimulation or really high levels intensity of stimulation. So we just ask people to kind of go along where their comfort, where the child can feel the stimulation, but also is still comfortable.
Okay. And so it sounds like you're using the treatment to send these magnetic waves, are sending these really low level pulses of electricity into the trigeminal nerve, which activates those areas of the brain that you spoke about, which are associated with ADHD. But you also mentioned that it can take is it 4 weeks it can take to see the benefits? Is that typically how long you would expect?
I would say so. It's not a medication. And so, very often in the first week, parents don't notice a lot of difference. And then kind of incrementally, there are small changes that add up over the course of 4 weeks. So, I think we are trained in this culture to expect results fast and things to happen really quickly. And this is not a medication treatment. So it does take, what we think is that it's a building level of activity, increasing activity in the brain that kind of, helps to make areas more active that were previously underactive. And that takes time,
Right. And so when we know that it is working, what are some things that parents can expect to see or maybe even hear from teachers? How do you know that the treatment is working for a specific child?
Sure. Well, so I think this is one of the non-medication interventions um, that actually have an effect on core ADHD symptoms. So we see improvements in both inattention as well as hyperactivity, impulsivity. But I would say the effect is potentially larger on inattention. And so, in our research study, we're taking weekly ratings. We do clinician ratings, and parents fill out forms to tell us, and we track the level of improvement of ADHD symptoms. And then actually, I'm just preparing a new paper where we are looking at kind of emotional lability and emotional reactivity. And so, because it's a very interesting finding. So in addition to kind of wanting to develop this treatment, the other thing I've been really focused on is finding predictors, right? So that when we think about a child and we've just made a diagnosis of ADHD, we also would like to have some information that would guide what kind of treatment would be the most appropriate, whether it's medication or non-medication or anything. I think that isn't too much to ask. And so we have really worked on trying to develop predictors that tell us a little bit more about who might respond to TNS, so that it isn't 50-50, that it is a higher likelihood that this child will respond. And so, the predictors have primarily been in the executive function domain. So we know that children, or what we've seen so far in our data, is that children that have more executive functioning deficits, as indicated by a parent reported brief, for example. So a rating scale that tells us about what their everyday executive functions look like. When they have elevated scores on that, and actually, because you're a neuropsychologist, so a T-score of 70 or greater, there is a much higher chance that the child will respond to TNS and trigeminal nerve stimulation. So while I was doing those analyses, that's now something we're testing in this new study is, can we predict treatment based on parent ratings on this brief and maybe something else? We know that EEG also is predictive, but that isn't very realistic for the clinic. So we're really trying to find maybe some combination of other sorts of measures, either behavioral or cognitive measures, that might help us predict who will respond to TNS. So we're doing our trial, and we have a lot of parents saying the ADHD symptoms are getting a little bit better, but the other thing we're seeing is that our children are less emotionally reactive, less dysregulated emotionally. And I had looked at our previous data set pretty carefully at all of our, emotion dysregulation measures, our depression and anxiety measures, and really didn't see any differences at baseline between those who went on to respond to the treatment and those who did not. But because of all these comments from the parents, I went back and changed my analytic strategy a little bit. And so instead of looking for differences at the baseline, I just wanted to look over the course of treatment, whether there are changes in, emotion dysregulation, emotional lability, and emotional reactivity. And lo and behold, there is something there. So another thing that parents may see, in addition to improvement in ADHD symptoms, is also an improvement in emotional reactivity and emotion dysregulation. I'm still trying to follow that and see. I need to learn more about that, but that's just hot off the presses, new finding.
Right. And that's really an important piece, because oftentimes parents will report, even with medication, that the attention is better, but those executive functions, that's the area where my child continues to need a great deal of support. And particularly when you're talking about that emotional regulation piece. So this is really exciting to hear that this may help with some of those symptoms.
Yeah. And actually, I do think that executive functioning is the core of there are core improvements in the brief as well. So kids go from a T-score of 70, which is kind of clinically impaired, all the way down to a T and as a group, 50s, which means they're fairly normalized. So if you ask me, what I think happens is that executive functioning gets better and it drives improvements in ADHD symptoms and emotion regulation.
Do we know how long the effects of TNS treatment last? So after, do they have to continue to wear the cap or the Band-Aid for an extended period of time? Do we know that yet?
We don't. In our first study, we did 4 weeks of treatment, and then we actually took people off of treatment for 1 week to see what the effect would be just over, discontinuing the treatment for 1 week. And we did see a slight increase in ADHD symptoms. So we know that, this is not 4 weeks and you're done, cured permanently sort of thing. In this larger study, we are now trying to test the effects of long-term treatment. And then we are actually comparing kids who decide not to, continue the treatment, either because they're not responders or, actually that's generally what it is. So when, we do have non-responders, not everybody responds to every treatment. And so those children basically discontinue and then we follow up with them at 3 months and at 6 months to just see how they're doing, what kinds of treatments they've decided to use, and whether those kinds of treatments are helping them. So the children who do respond to the treatment are actually, as part of the study, allowed to go into what we call our 12-month extension. So it's just an open label, and they will continue to receive treatment for a full year. And then we're going to follow them every 3 months, see what their behavior is like, see what the safety of it is, see if there are any side effects to ongoing use. So it doesn't actually answer completely that question of, how if you do 4 weeks of treatment and you stop, how long will the effect last? I don't know that answer, but my guess is that you would have to continue the treatment and then maybe taper and, wear it a little less often, but still need sporadic boosters, maybe. Our hope is that, as children are undergoing neuroplastic change with development, that this device will kind of help change the trajectory of their brain development so that eventually they don't need to use it because their brain is now completely, developed in the areas that were previously under functioning. And that's our hope. But I think there's a lot more research we need to do to figure out if that actually happens.
Right. And so we know that TNS is not a medication treatment. It's a non-medication treatment. Are there any side effects?
No significant side effects. It's certainly no adverse. We've not had any serious adverse events, anything like that. In our first study, there are side effects, not very frequent, but, sometimes there's headache. So one of the things that I've noticed with our parents is they're very eager to increase the level of stimulation, right? Because that correlates to more treatment. And so,
right.
Yeah. And so what we've seen is, when parents are a little enthusiastic to do that and they continue to try and bump up the stimulation, that can result in a headache because the stimulation level perhaps is too high. So we just actually ask them to bring the stimulation level down, and that seems to take care of it. We have seen, I think in our first study, we had some interesting findings around appetite and weight. There was a significant increase in weight and a small increase in appetite. And I think it's because the trigeminal nerve connects to an area in the brain called the hypothalamus, it actually connects to the brainstem, and then activation flows out into the cortex from there. But the hypothalamus is one hypothesized mechanism. And so the hypothalamus affects diet and hunger and maybe potentially, but it wasn't outside of normal limits. There wasn't anything terrible, but we do monitor height and weight for all kids now.
And do we know yet how TNS compares to medication or psychotherapy? Do we have any preliminary data regarding that?
So the best we can do, because we haven't compared TNS head to head to any medication treatments, for example, is through the use of an effect size. So that's comparing the effect within the treated group versus the effect in the placebo group. So based on that analysis, the effect size is about 0.5, which is a moderate effect size. It's actually similar to many of the non-stimulant medications that are being used to treat. In some cases, that's actually a big group of medications, right? So in some cases it's a little higher, and in some cases it's a little lower. But generally, I would say overall, the average is approximately similar to a non-stimulant medication. We know that the effect size for a stimulant medication is quite large. So, almost double that in the most acute studies where they're just looking at short-term response. So medications, I think, do have probably a larger effect size for those children who can tolerate it, who respond and don't have side effects. And I think, that's still the gold standard of treatment, but we just know that there are significant percentages of kids who don't respond or have side effects, ranging up to 30 to 40%, right? So this would be a good treatment option for people that, that don't want to try medication, because most parents don't want to start their child on medication if they don't need to. But then also, in terms of others who have tried medications and can't tolerate it, this would be a good thing to try. In terms of other behavioral interventions, for example, or dietary interventions, TNS actually has a larger effect size than I think all other non-medication interventions that I'm aware of on actually ADHD symptoms. So, for example, behavioral parent training is a very standard treatment and helps. Although the effects are primarily in reducing conflict and helping to, increase, ability to follow and through on, instructions and things like that. But the actual effect size on actual ADHD symptoms is not really very big. And so when I say the effect size of TNS is larger than other non-medication interventions, I just mean primarily directly on ADHD symptoms.
Right. Directly on. And so reducing the symptoms of ADHD as opposed to non-ADHD symptom improvements, like in parent-child relationship.
Right.
Okay. And sounds like part of the research that you're conducting will help to determine who would be a good candidate for a TNS intervention. And, you mentioned that it seems to have a good response to the inattentive symptoms of ADHD. Are we getting information about who would be a good candidate based on their presentation of ADHD? We know that there's the inattentive presentation, hyperactive, impulsive, and then combined. Who is eligible first, I guess, to participate in the study? Does it matter about the presentation of ADHD?
We take all presentations of ADHD. So children ages 7 to 12 years old have to be 7 to 12 when they start the study. So we've had some kids that are getting ready to age out, but if they're enrolled while they're still 12, that's fine. And we don't actually, the ADHD symptom severity and numbers of ADHD symptoms have been pretty similar between responders and non-responders. So we're not getting an initial read on whether a particular ADHD presentation will respond better. It's really because, not all kids with ADHD have executive functioning deficits. And so now that's not to say that, so there are, the non-responders also have some executive functioning deficits, but as an example, we know that executive functioning deficits are not ubiquitous in ADHD. Maybe about 50% of kids have executive functioning deficits. So it's not ADHD symptom presentation that seems to be telling us or very predictive of who's going to respond to TNS. I do think having executive dysfunction is a much stronger predictor. And then we're going to go ahead and test some other, and, emotion dysregulation may be part of that equation. I just haven't tested it yet.
Right. And so if parents are interested in enrolling their child in this study, this research that you're conducting, and they think that they're pretty sure that they don't want to try medication and they want to look at this TNS treatment as an option, what can they expect from beginning to end in terms of reaching out to your team, to actual participation in the study?
Sure. So we have an ADHD website set up. It's actually, if people could Google Semel Institute ADHD and Mood, for example, and that would pull up our website. And on the website, there's contact information. So there's a phone number, there's an email address, and there's actually a QR code. So people could scan that, and that actually leads to the screening questions that we use for the study. So there are multiple ways to kind of get in contact with us. So you would, in any of those situations, you would give us your name. We would have someone reach out to you. If you haven't already completed the phone screen, then one of our staff members will go through the phone screen with the parent and let them know whether kind of at this preliminary stage they seem to be. So, for example, we don't take children on medication who are currently taking medication because this is a non-medication intervention, and we really want to know how this treatment works without the presence of other treatments. So we have taken people who were previously on medication, but they can't currently be on medication. So it's just those kinds of screening questions. We also are not taking children with a comorbid diagnosis of autism spectrum disorder, for example. So there are certain inclusion and exclusion criteria that the phone screen will help us determine whether the family is a candidate and can participate. So then the next step, we will actually do a state-of-the-art diagnostic evaluation. So, and actually all of it is done virtually over Zoom. So there are basically a lot of it happens. No one has to come to UCLA campus. A lot of it can happen from the comfort of your home. So basically there's a diagnostic interview and behavior rating scales, and then a brief IQ screen that the child will do with one of our staff members. So they have to have a diagnosis of ADHD, and they can't have some of the other exclusionary diagnoses. If all of that goes well and they're eligible, then we will schedule them to come in for one visit. The visit takes about 2 to 3 hours on campus at UCLA. And both parent and child come in together. The child will do some assessments, some EEG and a couple of cognitive assessments. There will be an interview with the parent. The parent has lots of forms to complete. And then at that point, so this is a double-blind study. So there's only one person on our team that knows which treatment group people are assigned to. She comes over and teaches people how to use the device and helps them set an initial stimulation level. And then they go home and start the treatment right away with their child. And then we do weekly check-ins for 4 weeks. So again, these are just 15 to 20-minute phone calls where we just make sure everything is going okay, number one, with using the device, but then also behaviorally. So that happens for weeks 1, 2, 3. And then on week 4, they come back in and we do another assessment to see whether there's been improvement, how things have changed over the course of treatment. And then after everyone is done with their ratings, we break the blind and we find out if they were randomized to the active group or to the sham group. And so the sham group is also stimulation. It's just a lower level of stimulation. So then we make some decisions about basically clinical decision making, right? So and then if someone is randomized to the sham condition, they are given the option to cross over into the active condition. So they will then get 4 weeks of treatment. At the end of the 4-week treatment period, whether when they finally finish the active treatment, if they are responders, if their child is doing well and they want to continue the treatment for 12 months, then we will go ahead and continue to supply electrodes, and then we will also be, following them clinically to see how they're doing over the longer term follow-up period.
Wonderful.
Oh, and let me just mention two. So 2 visits, 2, maybe 3 visits. If they're randomized to sham, they have 3 visits on campus. We pay everybody for their time. So every visit, including the beginning baseline visits, are people are compensated. We pay for their parking, and then we also compensate the parent and child, and they have to figure out how to divide the money. But $25 each visit.
Okay, wonderful. And if parents and their child or children are not located in Southern California, is this a multi-site study where they can participate in other parts of the country?
So we do, yes, it is a multi-site study. We have one other site, which is actually up in Seattle, Washington, and that's Seattle Children's Hospital. And so they are able to pick, the procedures are identical at both sites, and they can pick either of those. We have had people call from Florida and from other states around the country, but TNS is commercially available. So basically, it's available by prescription from a doctor. And then still getting a little bit of clarification. I'm not part of the company, so I know nothing about the way their business runs. But someone was recently asking me at a meeting, like how do you get the device, and what are the inner workings of that? And so I need to find out more about that. But basically, the device is available. And the company has rolled out a payment plan that should make it very accessible. If you have insurance, they work with the insurance company, and the out-of-pocket is quite low, as far as I'm aware. They just rolled that out, I think, over the fall. So I tend to tell people that are thinking about flying in from Florida or anywhere else in the country, it's probably more efficient, and both in terms of time and money, for you to just get a prescription and give it a try rather than flying in for the 2 on-site visits.
Right. And it sounds like something that they can talk to their child's pediatrician about, how to go about getting that intervention.
Yes. Although I will say, part of my job is also to get the word out to a wide range of professionals, right? Because they're just, people don't, it's a new thing. So it's helpful to have information. I do believe the company has a YouTube video on how to use the device, but I've been talking to lots of pediatricians, developmental behavioral pediatricians, psychologists, psychiatrists, neurologists about, how to how do you do it sort of thing? How do you help patients start this treatment? So I'll continue to work on that.
Yes. And that's the way we advance our understanding of ADHD and its treatment and intervention is through clinical research. And that's how we found out about the efficacy of medication and some other interventions. And so the work that you do is so important and necessary to advance our understanding of ADHD, who responds to treatment, what does that response look like, and who would be a good candidate for TNS intervention.
Thanks. Yeah, no, I am super excited we want to do the science so that we understand, does this work? For whom does it work? How does it work in the brain? So that we understand what this is before we, recommend it to our patients.
Absolutely. Dr. Loo, thank you so much for being here and for sharing this information with our listeners. We are definitely going to put links to the UCLA website where they can go to access the screening and to learn more about the study. So thank you so much.
Thank you. Thank you. And please, anyone, feel free to contact us.
I am so grateful to Dr. Loo for coming on the podcast and sharing this information with us about this non-medication treatment for ADHD. If you would like to know more, make sure you check out the show notes. There is a link to the flyer and the website where you can find more information directly. Thank you so much for listening. Until next time.
Thanks for listening to Diverse Thinking, Different Learning by Child Nexus. For more resources, visit us online at childnexus.com.